Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is anesthesiologist and fellowship trained in pain medicine, Dr. Stephen Frost, here from Rapid City. Chronic pain is kind of what we're going to talk about a little bit today, Doctor.
Yes.
From cancer or from other, just from other conditions that people can have. It's got to be incredibly challenging, both physically and emotionally, for these people that experience it. But I think there's a lot of great advancement that you have seen in your career that we want to talk about here that are really helping people through this. Would that be fair to say?
Yes.
One thing we want to focus on is the intrathecal pain pump. Did
Correct.
I say that right?
You did.
Yes. I practiced for 2 weeks on that one. But this is kind of a specialized approach to pain medicine. So let's start with the basics on this, Doctor. What exactly is an intrathecal pain pump?
Well, it's a pump and has a reservoir, so it's about the size of a hockey puck.
Okay.
And we place that underneath the skin in the abdomen, and we tunnel a catheter from the stomach area all the way to the back, and it's placed in the intrathecal space, which is the spinal space. And the whole concept is to get pain medication, an opiate, directly to where it needs to go. What's the advantage? Well, it's 300 times stronger. So, for instance, if you're on 300 milligrams of morphine a day orally, I only need to put 1 milligram of morphine in the intrathecal space.
Why is that? Why does it work so much better, I guess?
Well, first of all, it's going directly to the pain receptors and blocking the pain. That's where they're at in the spinal cord. To get that much medication across into the spinal cord when you take it by mouth, it's got to go through the liver, the intestines, throughout your whole body. So that's why you need 300 times more to get the same effect. So you get superior pain control and less side effects. 1 milligram in your body versus 300 milligrams, you can understand you're going to have less side effects.
Absolutely.
And either for cancer pain and or non-cancer pain, the more you have to increase the dose to help with the pain, the more side effects you're going to get.
Right.
And the classic side effects, confusion, anorexia, nausea, vomiting, constipation, itching. People are just out of it.
Mm-hmm.
But if you don't give them enough pain medication, they're in severe pain.
Right.
So this is where the pain pump comes into play. We follow the World Health Organization guidelines for treatment of pain, either whether it's cancer pain or non-cancer related. The first step, take 2 aspirin, call me in the morning. That works. Anti-inflammatories, Tylenol, non-opiate medications. Then you can go to weaker opiate medications like a Vicodin, people have heard of that,
mm-hmm.
or Percocet or oxycodone. And if that doesn't work, you go up one more step, and then you can go to the higher, like the pain patches like fentanyl, methadone, and then once you try all those steps and you're still having severe pain, that's where the pain pump comes into play.
Now, it seems like, because we've heard about the opioid epidemic that is happening. Is it something that you as a pain doctor, I mean, I know it's effective medication.
Yes.
But do you hope that at some point we move away from that in finding these new ways to manage pain?
Yes. There's actually a new medication that just came out orally that does not block pain at the mu receptor, which is how narcotics work.
Uh-huh.
It's a different mechanism, so it doesn't have the psychological dependence and the side effects of it. Yes, I'm excited that they're actually looking at non-opiate ways, narcotics or opiates, to treat pain.
Well, you have been involved in this almost your entire career, right? You were telling me you're local. You're from Rapid City.
Yes.
You're born and raised here. You've spent your entire career here.
Yes.
And you were the first pain management doctor in Rapid City.
Yeah.
A lot of things have had to have changed since. What were you doing 30 years ago to help people that had these types of pains?
Mainly giving them pain medication.
Yeah.
And then we do certain types of blocks, which we still do today as we did that many years ago. But before I started, now we are doing what's called radio frequency, where we can burn the pain nerves so they can't transmit pain to the brain. And we can do that throughout the entire body. The pain pumps literally came out right when I started practice. We didn't have any in my fellowship, so that I kind of learned as I went. And like I said, there's been fewer newer medications out there since I started, where before they never had them, that were non-opiate that can treat nerve pain. And so, yeah, there's been great advances, but we still have room to, it would be a great goal if we could treat pain without ever using an opiate.
Why is it so hard to treat pain? I mean, I know that seems like a kind of a basic question, because all of us have experienced it.
Right.
Right. In different ways, in different forms. And it's all based around your nerves, correct? Right. That's where all of the pain comes from. Why is it so difficult to combat chronic pain?
Well, by definition, chronic pain is any pain you've had for greater than 2 or 3 months.
Okay.
And your brain and spinal cord actually change how it processes a pain signal, so where it makes it more difficult to treat. And like you said, we've all sprained our ankle. Mm-hmm. We all lift up that box when we shouldn't have. And usually your body sends its own mediators, and you get better.
Right.
But there are certain pain states where you never get better, and the pain continues. And again, if you've had pain for quite some time, it affects your entire life. Mm-hmm. I mean, you will clinically get depressed.
Right.
I can no longer go out and walk my dog. I can't clean the garage. I can't do the dishes anymore. So the most common pain we treat by far would be back pain.
Right.
Slip disc, arthritic. Mm-hmm. And that's where we can do injections, mild analgesics like anti-inflammatories and Tylenol, and we can really help people so they don't have to go to a surgery or anything like that. But once that pain stays around for 4-6 months, it definitely becomes more of a way we can help them cope with the pain, knowing that there's no magic cures. There's no 100% guarantees what we do. But things such as this pump definitely has clinically shown through studies that, 1, reduces pain, 2, reduces toxicity, the nausea, the constipation, and all that. And actually, 3, it's for cancer pain has shown to help increase survival. It doesn't cure the cancer,
right?
But if you have less stress on your body, it makes sense. You're going to be able to help with your oncologist fight the cancer better.
Oh boy, never even thought of that.
Yeah. And then it actually saves money. Mm-hmm. Taking oral narcotics is expensive, and then when people have cancer pain, when they have severe pain, they go to the emergency room, go to the hospital. The spinal pump has actually shown that it's decreased the amount of admissions patients with oncological pain have, the length of stay, so they don't stay as long. So, again, right now we have shortages of basic morphine orally right now. It's hard to find that in pharmacies. I just got back from a conference in D.C. It's nationwide. Drugs that have been around since the dawn of time, there's shortages. So that's, the spinal pump definitely is, you try everything first before you do it.
Yeah.
But when you're there, it really can help the patient.
What specific drug is being used in that pump?
It's indicated for morphine.
Okay.
Yeah. And again, with a lot of medications, you can go off-label and put other medications, like a local anesthetic like a dentist would use, bupivacaine. We can put blood pressure medications in there. It's called clonidine. It, again, blocks pain a different way. There's actually ziconidine, which is, I'm always amazed how I call the smart docs come up with these ideas. It's actually was a snail had venom in the coral reef in Australia, and they somehow figured out that can stop pain. And now we put that in the pump, and it's only made for the pump. So
really, I always wondered the first guy that tried it. Like,
Right.
was he holding the snail, or
I know.
or what happened?
I-
Bit into it. I don't know.
Well, it's kind of like Botox.
Right? Yeah.
Whoever
Sure.
thought Botox is, of course, used to keep us pretty. In Grandma's cooking jar, it would kill you.
Right.
And then somebody said, "Whoa, wait, let's see what we can do
Let's
with that."
inject it into you.
And they did. It helps with headaches. I mean, it's amazing what they come up with, and I'm glad there's smart people out there.
Yeah.
And I do what they have researched
Right.
and come up with.
Now, once the pump is in place, can it be there permanently?
Yes.
It can be.
Yeah. I've been in practice about 30 years now, and I still have patients who don't have cancer pain with a pump. It lasts about 5 years before the battery runs out.
Oh, of course.
And then you just unzip, put a new one in, zip it back up, hook it up to the catheter. The catheter can stay in for lifetime.
Mm-hmm.
And like I said, I've had one patient I've had for 27 years, and it's really helped her pain.
Wow.
And so in the concept, again, like I told you, you put the medication where it needs to go. These pumps now are so far advanced. If you've ever been to a hospital and had a surgery and you had an IV, it's called a PCA, where you can push a button to get more pain medication. Otherwise, it runs continuously
Right.
every hour. That same thought can be put in the pumps. So they have a controller where we run it continuously at a constant level, and if they have increased pain, all they got to do is this little cell phone. They hit the button and they get more.
Is there a danger to misuse it?
There's always going to be the bad apples out there.
Yeah.
The way the pump is underneath the skin, and what we do, it's like a fuel tank. The medications last about 3 months before they start to disintegrate. So you take the nurse, usually you come in the office, and they prep the skin. They put a needle in the middle of the pump, withdraw the old medication, put the new medication in. So there are bad apples out there that could do it themselves.
Right.
But that's very rare.
Sure.
And you actually have to know what you're doing, too. So,
Oh, I bet.
yeah, the risk of the pump are very minimal. Patients, especially in their time of cancer pain, a lot of emotions are going on. And pain, obviously, is probably on top of their list.
Right.
Because cancer pain across the board, 80%, 90% of patients will have pain. But the majority of those can be treated with oral medications. But the ones who cannot, this is where the pump is the cat's meow, because you put the pump in, you can get them off their oral meds. A lot of times you can get them off completely. And so they're not walking around like a zombie and don't have the side effects. They can enjoy their family. They're alert, and the pump continuously is working. So the side effects, it's a surgery, but it's a walk in, walk out, same day surgery.
Oh,
it's
really?
almost
Okay.
like getting a port for
Yeah.
cancer treatment. Usually a neurosurgeon puts it in for us, highly skilled, trained. So, always risk of any surgery, infection.
Right.
You can get a spinal headache, but that can be treated at a later time. And the medications, obviously under physician's control, there's less side effects, so it's very rare that a patient would overdose or
Right.
respiratory depression, or that you just don't worry about because you're not putting that much medication in.
Got it. So what, I think you kind of touched on a number of these anyway. The criteria that you use to determine if someone is a candidate for this. What is that criteria you generally look for?
Well, we look for, first, what type of pain they have. Before, when I first started out, we would just put the pain catheter in the spine and think it would flow up and down with the spinal fluid, because your spinal fluid continuously flows from your head down to your tailbone all the way back up. Later years, the research showed no, the medication just sticks where the catheter is. So we since have learned that you got to put the catheter where the pain is. So if it's up in the shoulders, you go all the way up to the neck. If it's in the stomach area, like pancreatic cancer, you put it right in the middle of the spine. And so we look at what type of cancer, where it's located, what type of medications have they been on, and what is working or what has not worked. I mean, we always want to exhaust oral medications because it's easier.
Right, of course.
But you also want the patient to know that it's better to get it in earlier than later because you will get a lot more benefit. So typically the patient will work for cancer pain where they're oncologists, and when the oncologist notices that they're having to really escalate the pain medication dose, that's usually when they'll refer them to us.
Okay.
Yeah. You can do if you have no cancer pain, and let's say you have had 8 back surgeries, multiple injections have tried, multiple medications have tried. What you can do is a single shot, kind of like getting a spinal block. You put a little morphine in there, and you can do a test block so the patient can actually see what it's going to feel like. And it's amazing. When you do that, these patients are just ecstatic.
Oh, I bet that feeling when it's not there anymore.
It's not exactly.
Has to be euphoric at that point.
Oh, yeah.
Wow. Well, you guys must have, this has to be kind of a team effort, though, with oncologists and nurses and everything to get the most effective use out of this, isn't it? Do you work closely with them as well?
Yes.
Okay.
Yep. Like I said, we work with the oncologists. We work with palliative care physicians. They're usually the ones who can handle most of the medications, but then they know, oh, wait, we're only getting side effects. We're not getting pain relief. And then, like I said, we usually work with a surgeon, a neurosurgeon, to put it in. And then the pain management team manages the pump. What's really been great since we started this is we work with a company where the nurse actually goes to the home and changes the medications. At end of life, a lot of patients just can't get out.
Right.
And so it's difficult to come to the clinic or hospital. Now we have the nurse coming to their home. And even our non-cancer patients, we're having the nurse coming to their home. And that's all that nurse does. She doesn't do ports or she only refills pumps, so she's very excellent at her job. So we know it's safe.
Okay.
Yeah. So that's and like I said, in our Rapid City area, we're an island and we draw from 300 miles. Some of these patients are rural, live far out, and they can't drive 2 hours in to get a pump refill. But the nurse can come out and refill it.
Boy, that's quite a service.
Yeah, it
really
is.
I mean, and that's got to, for people listening right now that are considering this maybe, that are thinking, well, yeah, I can't make a 4-hour round trip to do this, whatever. To hear that, boy,
yeah,
that's a game changer for you guys, kind of.
And it's scary, people. Another surgery, and as I said, it's like getting a port. It's a same-day procedure, a very minimal risk. It's not that you're giving up. You're actually getting pain relief so you can live longer,
right,
and enjoy your life with your friends and your loved ones.
Yes, exactly.
Without being zoned out.
Now, do you think we'll ever? do you think we'll ever get this whole pain thing figured out, or is it just too? I mean, the nerves in our body obviously are almost endless. It seems like, right? Just for where they go and how they end up and how they work.
Yeah.
I didn't really say that very professionally, but I think you know what I'm talking about. Will we get to a point where we can figure this out all the way, do you think?
Probably not.
Yeah.
That's the problem with the nervous system and more. You know, pain, some folks psychologically will get secondary gain from it. We're never going to stop that. But the majority of patients, and that's why I chose this field, is that these patients are giving up primary care, don't know what to do. They try their best, and they kind of, I don't know what else to do.
Right.
And once the patient comes to the pain clinic, that's our whole focus, so we can spend a fair amount of time with them initially, which is refreshing to the patient, knowing that there are answers. There's no 100% guarantees, but there are guarantee we can help you cope with your pain.
Yeah.
And so just that alone, I think, brings a lot of relief to the majority of patients with both cancer and non-cancer pain, that there is hope. And if A doesn't work, we're going to go to B, and B doesn't work, we're going to go to C, and we're going to find something.
Right.
Yeah.
Are you guys finding any use yet for artificial intelligence? The AI is becoming a big deal in medicine. Do you think down the road that this might open some doors?
Oh, definitely.
Really?
I think AI is that's the best thing AI is going to help. All the data that we'll have with electronic charting now. I was back in the days where it was paper charting.
Yeah, all the handwriting you had to do.
Yeah.
Oh, boy.
So AI is going to say, this many patients had this type of treatment and worked better. This part didn't. It's interesting. I read Bill Gates said in 10 years we won't need doctors. AI will, you plug it in.
I never believe that.
Yeah, we still need people to cut and open organs and hot appendixes. And
yeah, I still want a person in the room when that's going on for sure.
Don't want a robot by itself.
No, I don't.
But the data will definitely help us drive which is the best way.
Yeah.
Because it just won't be what's in Rapid City. It'll be the entire nation, what treatments work. So
yeah, it'll all be kind of linked together, and you get to find out. Yeah, you get to draw from the best info that's out there.
Yeah.
So if somebody is listening to this and they are interested, what are the first steps they should take with their primary care doctor first? Is that where they should go?
Yes. Usually we're a referral base only pain clinic because we're so busy, and we have them, if they call the clinic, we have them just say, have your primary care refer, and we'll get you in as soon as possible. And again, with the cancer pain, they'll be already set up working with the oncologist and the palliative care physician. And so that is already in the pipeline, and they know. I see two types of pain as soon as possible, and that's cancer pain. I'll see them that day or the next day. There's a certain pain syndrome called complex regional pain syndrome. I'll see them immediately, too. Back pain that people have had for 10 years, I'll see them when I can get them in. Yeah.
Well, and that's something that we've all experienced.
Yeah.
And, obviously it's worse for some than for others. Do you guys, is there any expansion plan with you guys? Are you trying to grow out the clinic for you here at Monument?
Yes, we're at the sports hospital.
Oh, yes.
That's where our clinic is, and we have two physicians a day there, and we have up to 4 nurse practitioners at a time.
Okay.
And then they work closely. The nurse practitioners will see the patient initially, and then recommend injections, medications. And then typically the physician does the injections.
Right.
So
okay.
We obviously, when you build a new building, the first year you'll say, why didn't we build it bigger?
Right, of course. Well, and Monument's been expanding so much now too.
Oh yeah,
which has been wonderful for our, for Rapid City, and like you say, this 200-300 mile radius.
Right.
It's only going to improve people's lives that live here, and having doctors like you that have dedicated to staying here,
right,
because you get to know these people, and I think that we've had conversations with doctors, and what I'm hearing and seeing is that is becoming so very important in helping people get better, is knowing that I'm not just cattle going
right
in and out, right? Do you feel that too?
Oh yeah. And I trained as an anesthesiologist,
Mm-hmm.
and I wanted to come back to Rapid City, but they didn't need another anesthesiologist. But they said, no one's doing pain here. And I said, well, that'd be great. Anesthesiology, I put the patient to sleep, they wake up and they forget me. I've done my job.
Right.
But I kind of became a doctor to get to know my patients, and pain management was a great avenue for me because it's chronic. And sure, I get a lot of patients we help out, and I don't ever see them again. But like I said earlier, I have a patient I've been seeing for 27 years. You get to know them, become friends, and you still help them.
Yeah.
So I kind of had the best of both worlds.
That's awesome. That's awesome. Well, this has been really fun to talk to you today, Doctor. And I would love to drill down some other stuff too that you're super interested in when it comes to pain management and how this works.
Sure.
Dr. Stephen Frost, anesthesiologist and a fellowship in pain management as well here at Monument. Thanks for coming in and talking, Doctor. I really appreciate it.
I enjoyed it. Thanks.